Good evening, everyone. At the outset, I want to thank AOMSI for giving me this opportunity to speak at this AOMSI virtual masterclass. My topic for today's presentation is Principles of Distraction Osteogenesis in Mandible. So while understanding this topic, we'll try and understand what is distraction osteogenesis, what are principles of distraction, various stages of distraction osteogenesis, indications and contraindications of distraction, types of distractor devices which are available. We will try and understand what is transport distraction. Then we will look at the clinical applications of distraction osteogenesis pertaining to mandible. We will see the complications of distraction osteogenesis, what are recent advances, and then we will conclude. Now, distraction osteogenesis is basically a tissue engineering method which can be integrated with various craniomaxillofacial surgical techniques so as to generate a new bone by surgically stretching the osteotomized bone segments with the help of a device which is called as distractor. Now, this technique basically utilizes the fundamental principles of healing in human body by inducing regeneration and remodeling of the callus between the two osteotomized bone segments. Distraction osteogenesis does not only create new bone, but it also stimulates a phenomenon that is known as distraction histiogenesis or neohistiogenesis, where the surrounding soft tissue simultaneously expands and stretches and covers the newly formed bone. So distraction osteogenesis also brings about distraction histiogenesis, that is new soft tissue formation. Now, historically, distraction osteogenesis was first described by Cordovilla long back in 1905. But it was Gavril Ilizarov who performed extensive studies on distraction osteogenesis, especially in the long bones, and described something called as Ilizarov effect. Now, this Ilizarov effect is also called as stress tension effect. Now, according to Ilizarov effect, what does it states is that when we apply tension on the osteotomized bone segments, it stimulates formation of new bone. And this new bone formation occurs along the direction of tension. So stress tension effect is also called as Ilizarov effect, and it simply states that there will be new bone formation in the area of bone where tension is applied along the osteotomized bone segments. So there are different stages of distraction. The first stage is the osteotomy stage. Second stage is the latency stage. Now, this latency stage basically is a time taken by the osteotomized bone segments to form granulation tissue between the osteotomy. This typically lasts between 5 days to 7 days. So in very young individuals, the latency period is shorter, that is around 5 days. And in very elderly individuals, the latency period is longer, that is around 7 days. The third stage is stage of distraction. Now, after the granulation tissue is formed and primary callus begins to form between the osteotomized bone segments, the segments are gradually activated and they are separated from each other. Now, this is achieved by activation of distraction device. The distraction is carried out typically at the rate of 1 millimeter per day. Now, this 1 millimeter per day can be split into half a millimeter 2 times a day, or it can be split into 0.25 millimeters 4 times a day. Now, after the desired amount of distraction is achieved, the distractor device is left with no more activation, and that phase is called as phase of consolidation. Now, the phase of consolidation typically lasts anywhere between 8 weeks to 12 weeks, and during this phase, the primary callus, which was molded during the phase of distraction, it undergoes maturation and it consolidates into formation of secondary callus or mature bone. Now, after the consolidation phase is over, the newly formed bone undergoes extensive remodeling, and this remodeling reshapes the bone to restore the original contour of the bone, and it also creates the patency of inferior canal like what should occur in the normal mandible. So these are different stages of distraction osteogenesis that we all should be very well versed with. Now, this is a diagrammatic representation of different stages of distraction osteogenesis. The first diagram indicates the latency phase, when after the osteotomy is done, in first 5 to 7 days, the blood clot gets replaced with the granulation tissue, and this granulation tissue starts getting replaced with the primary callus. The second diagram indicates the phase of distraction. So as we activate the distraction device, we gradually separate the bony segments from each other. And once the bony segments are separated from each other, as per the Elizarov effect, the bone formation starts at the edges of osteotomy. Now, during early consolidation phase, the bone formation that has started at the edges of osteotomy, it starts migrating towards the center, and the primary callus starts getting replaced with the secondary callus. During the late phase of consolidation, the entire osteotomized bone segment or entire distraction gap is filled up with secondary callus, which extensively undergoes remodeling. And this remodeling restores the original contour of the bone. And in mandible, it also restores the continuity of inferior alveolar canal, as we can see in the last diagram. So these are different stages of distraction osteogenesis. Now, what are indications of distraction? As we all know, distraction osteogenesis is indicated in cases of mandibular hypoplasia, which can be secondary to conditions like temporomandibular joint ankylosis, or it can be secondary to hemifacial microsomia or golden hair syndrome. Mandibular hypoplasia occurring in craniofacial syndromes, the most common syndromes are Treacher-Collins syndrome, Pierre-Robin syndrome, and Nager syndrome. It is also indicated in cases where there is transverse deficiency of mandible with subsequent posterior crossbite and dental crowding, in short vertical height of mandibular alveolus to receive the dental implants, and in cases where there is segmental defect of mandible is present, which is secondary to tumor resection. So these are routine indications of distraction osteogenesis in mandible. Now, there are certain contraindications that we should know. First and the most important is unwilling patient. We all know that distraction osteogenesis is a long process and it requires patient cooperation. If patient is not willing to wear the distractor device for a longer duration of time, these patients are not indicated for distraction osteogenesis. A relative contraindication is infants who are less than 6 months because of the fragility of bones. Inadequate bone surface to accept the distraction device is again a relative contraindication. We should be very cautious in performing distraction osteogenesis in patients who have undergone radiation therapy. As we all know, there is deficiency of stem cells or osteogenic cells in those patients. So the distraction yield may not be satisfactory. And we all should be careful in doing distraction osteogenesis in very elderly patients purely because of decreased number of mesenchymal stem cells in these patients. So these are some of the contraindications for use of distraction osteogenesis. Now, there are different types of distractor devices which are available in the market, and they can be classified in different ways. One of the most common classification is according to the vector of movement. Now, in this classification, the distractor devices can be classified as a unilateral or unidirectional or a monoplonar distractor. Now, as the name suggests, these are the devices which allow the distraction to occur in only one vector. So it can be supero-inferior, it can be antero-posterior, it can be transverse. A bidirectional or a biplanar distractor will allow the distraction to occur in two directions. So it can simultaneously bring about a vertical distraction as well as antero-posterior distraction. And then there is something called as multiplanar distractor, which can bring about movement in supero-inferior, antero-posterior, as well as transverse direction. So that is classification based on the type of vector. The next classification is according to site of fixation of device. In this, the distractor devices can be internal or it can be external. Now, as the name suggests, an internal distractor device is completely buried under the soft tissues, except the activation arm, which will either come out intraorally or extraorally. On the contrary, an external distractor device is present outside the soft tissues. So extraoral distractor device is known as external distractor. The next classification is based on the site from where the distractor device its primary support. So in this classification, the devices can be categorized as a tooth-borne device, the devices which purely derives the entire support from the tooth-bearing segment of the mandible. It can be a bone-bone device, the device which derives its support from the mandibular bone, and it can be a hybrid device, a device which derives support from the tooth-bearing segment as well as the bone. So let us look at the clinical applications of distraction osteogenesis in mandible. To clearly understand the clinical application, we will categorize these applications under 4 different headings. First, we will talk about alveolar distraction. Then we will talk about mandibular distraction. Then we will discuss transverse distraction. And last, we'll speak about transport distraction. So alveolar distraction, as the name recommends, is the distraction osteogenesis performed to increase the height of the mandibular alveolus. Now, the most important indication is in patients where the height of the alveolus is severely reduced and it is very difficult for us to replace the missing dentition with the placement of implant. So patients who have deficient alveolus who desire replacement with dental implants are indicated for alveolar distraction. Now, the case selection is very important here, as the amount of bone remaining should be sufficient enough for us to securely place the distractor device in place. And while doing the osteotomy, utmost care should be taken to prevent the palatal or the lingual mucoperiosteal flap so that the vascularity of distraction segment is maintained to bring about normal healing. Now, with alveolar distraction, a vertical distraction of almost about 12 to 15 millimeters can be easily carried out. So that is the first indication of distraction in mandible, that is alveolar distraction. Now we will look at the mandibular distraction. And for ease of understanding, we will subcategorize mandibular distraction into distraction involving ramus of the mandible, body of the mandible, and symphysis. Now, when we talk about ramus of mandible, there are certain cases where there is severe shortening of the vertical ramus of the mandible. And these cases can be secondary to temporomandibular joint ankylosis. They can be hemifacial microsomia or condylar agenesis. Now, when we speak about temporomandibular joint ankylosis, we all know that in cases of unilateral temporomandibular joint ankylosis, there is severe shortening of the ramus on the ankylosed side. And on the non-ankylosed side, the length of the ramus is normal. And that leads to development of typical facial deformity in unilateral TMJ ankylosis patients. So the role of distraction here is to bring about lengthening of the mandibular ramus on the ankylosed side. Now, while performing this distraction, care must be taken to ensure that the distractor is placed parallel to the posterior border of the mandible so that the direction of distraction will simulate the original ramus of the mandible and will bring about a natural outcome. So that is vertical ramus distraction in temporomandibular joint ankylosis patient. Next, we will discuss about hemifacial microsomia. Hemifacial microsomia, we all know, is a syndromic condition which is characterized by malformation or agenesis of mandibular condyle or temporomandibular joint per se. Now, what is happening here is because of malformation or agenesis of temporomandibular joint, there is shortening of the ramus on the affected side. And because of the shortening of the ramus on the affected side, even the maxillary dentoalveolar segment is shortened on that particular side, and that leads to development of severe occlusal canting. Now, these patients typically require combined maxillomandibular distraction for correction of their facial deformity. So here is a young girl with hemifacial microsomia of the left side. Now, what you can notice here is that there is severe occlusal cant. There is shortening of the ramus on the left side. The length of the ramus on the right side is normal. And there is subsequent shortening of the mandibular alveolus on the left side as compared to right side. Now, this patient underwent LEFO1 maxillary osteotomy, a horizontal ramus mandibular osteotomy. The distractor device is fixed on the mandible, parallel to the posterior border of the ramus. Patient is kept into maxillomandibular fixation, and combined distraction of maxillomandibular complex was performed. Now, this is the same patient after about 10 millimeters of distraction done. You can see the occlusal cant is almost completely eliminated. The next indication is severe deficiency of mandibular body. Now, as we all know, in bilateral temporomandibular joint ankylosis, there is vertical as well as anteroposterior deficiency of mandible. And these patients typically have a bird face appearance. Now, what you notice here is a young girl who had history of bilateral temporomandibular joint ankylosis with absolutely no mandibular corpus length. And this patient underwent body distraction of mandible bilaterally. So while performing body distraction of mandible, the care must be taken that the distractor device should be placed parallel to the occlusal plane or parallel to the lower border of the mandible so that original anatomy of the mandible can be restored. So a typical osteotomy is performed at the angle or the body region. The distractor device is fixed, and after the desired latency period is over, the distraction device is activated so as to bring about anteroposterior increase in the length of the mandible. So this is the same patient after she underwent about 17 millimeters of mandibular distraction. Now what you notice here is the distractor device is completely fixed internally with only activation arm which is coming out externally. This is the activation arm that can be seen here. Mandibular corpus deficiency in syndromic patients like Pierre-Robin syndrome. Now, Pierre-Robin syndrome clinically is characterized by severe mandibular hypoplasia, retropositioning of the tongue, which is known as glossoptosis, cleft palate, and this glossoptosis and mandibular hypoplasia subsequently lead to upper airway obstruction. Now, this is a typical diagrammatic representation of patient with Pierre-Robin syndrome. Now, what we notice here is there is severe micrognathia leading to shortening of the ramus of the mandible and the shortening of the body of the mandible, and enlarged and posteriorly positioned tongue. It causes obstruction of the upper airway leading to breathing difficulty. Now, Pierre-Robin syndrome is one of the indications where early distraction osteogenesis or neonatal distraction osteogenesis is indicated. Now, this is a typical patient that I have taken from one of the textbook who underwent distraction osteogenesis for correction of mandibular deficiency secondary to Pierre-Robin syndrome. Now, what we notice here is in 10 days, there is significant amount of gain in the mandibular length, and subsequently, there is improvement in the upper airway that restores normal breathing in these particular cases. So that is indication of distraction osteogenesis in Pierre-Robin syndrome. Similarly, one of the most common syndrome that can lead to mandibular deficiency is Treacher-Collins syndrome, which is also known as mandibulofacial dysostosis. Now, this syndrome typically is characterized by antimongoloid slanting of the palpebral fissures, colobomas or notching of the lower eyelids, hypoplasia of mandible and zygomatic bone, absence or malformation of external ears, cleft palate, and subsequent breathing difficulty. Now, this is a typical patient of Treacher-Collins syndrome. And what you can notice here is there is shortening of the mandible or mandibular hypoplasia. There are malformed external ears, antimongoloid slant in the palpebral fissure, olobomas of lower eyelid. There is hypoplasia of the zygomatic bone, and there is narrowing of the upper airway secondary to hypoplasia of mandible. So these are typical clinical features of Treacher-Collins syndrome. Now, these patients also require mandibular body distraction, and this patient has undergone mandibular body distraction with the help of an external device. So the previous case we saw with the bilateral temporomandibular joint ankylosis, she underwent distraction with the internal device, and this patient has undergone distraction with the use of external device. Now, similarly, a transverse deficiency of mandible can subsequently lead to severe crowding in the mandibular arch. And because of the narrowing of the mandibular arch, it can lead to development of posterior crossbite. So what we notice here is that there is crowding in the lower arch and there is posterior crossbite bilaterally. And this typically indicates that there is transverse deficiency of mandible. And these are the patients who are indicated for transverse mandibular distraction. So this patient typically has undergone a midline mandibular osteotomy. Then a hybrid distractor device is fixed on the dental segment as well as on the symphysial bone. and the distraction is performed after completion of latency period. Now, what you notice here is there is good amount of bone formation between the osteotomized segments, and the dental crowding is now converted into dental spacing because of regaining or because of creation of new bone. So that is midline mandibular distraction or transverse mandibular distraction for correction of transverse deficiency of mandible. Now we will talk about something called as transport distraction. Now this is a unique type of distraction that can be performed for correction of segmental defects of mandible or maxilla. So in these cases, the designing of distractor device is of very much importance, because the distraction device is going to decide the shape of the bone yield and the type of the new bone that is formed across the segmental defect. Now, in transport distraction, as we all know, it is indicated in cases where there is significant bony defect is present. The defect can be secondary to post-ablative procedures such as segmental mandibulectomy, which can be used for treatment of large aggressive cyst or a benign tumor of jaw. Now, in transport distraction, there are certain things that we need to understand. Is that there is a big bony gap that we are trying to bridge with the formation of new bone, and we are trying to move a bony segment from the donor side to the recipient side. So the bony segment that is going to be transported to the recipient site is known as the transport segment, and the area which is going to receive the transported segment is called as docking site. So the principles of distraction are almost the same. After the latency period is over, the transport segment is moved along the path of the distractor device and it meets the docking site, and then it is left in place for consolidation so that there is bony union between the transport segment and the docking site. Now, while performing transport distraction, comprehensive planning is of utmost importance, and predetermination of osteotomy design and vector are also of paramount importance in ensuring the right positioning of the transported segment from the donor site to the targeted site. The most challenging aspect in transport distraction is to ensure adequate vascularity and maintaining an intact distraction chamber. As we all know, if we don't maintain the proper vascularity of the transport segment, or if we don't maintain the integrity of distraction chamber, we will end up with severe resorption of the distraction segment, and that will create even more severe bony defect from where we started off with. So let us look at the recent advances in distraction osteogenesis. Now, we all know that patients who are undergoing distraction osteogenesis require manual activation of distraction device at least 2 times every day or sometimes 4 times every day. And for this activation, either they have to remain admitted to the hospital for a protracted period of time, or somebody back home need to take the responsibility of activation. So to overcome this disadvantage of distraction osteogenesis, automated continuous mandibular distractors were devised. And these are the distractors which actually bring about continuous activation of the distraction segment, and they do not require manual activation. Now, these devices basically work on 2 different principles. The first device that we see on the left side is a battery operated device. So with the battery, there is a power supply, and this power supply brings about gradual activation of device over a period of 24 hours. And the activation brings about 1 millimeter of separation of bony segments. The other device that you see, it works on the hydrostatic pressure. And this also brings about 1 millimeter of distraction every day. Now, the major disadvantages of these automated distraction devices are the size of the distractor. Because of this battery and hydrostatic pressure and everything, the size of distractor device is quite big, and it can be a little difficult to carry. And second, and the most common major disadvantage of these distractor devices is the cost involved. So they can be significantly expensive as compared to conventional distraction devices. So now let us quickly look at the complications in distraction osteogenesis. For ease of understanding, the complications can be categorized as potential mistakes, potential complications, complications related to hardware, and complications involving hard and the soft tissues. Now, potential mistakes can be all iatrogenic mistakes, poor patient selection, poor decision making while correcting the initially developing complications, improper fitting of the design, improper placement of the distractor, and wrong activation protocol. Potential complications include malformation of bony regenerate, axial deviation of the distraction leading to axial deviation of the bony yield, overstretching of the soft tissues, which can lead to soft tissue breakdown either intraorally or extraorally, subsequently leading to development of infection. Hardware related complications can be difficulty in device activation, improper vector of the device, inadequate length of the device. We wanted 20 millimeters of distraction, but we have selected only 15 millimeters of distractor device. So that is inadequate device length. Unstable device, device deformation and breakage of the device during activation, and pin loosening that is typically seen with the external distractor devices. Hard and soft tissue related complications can be pain and development of infection, hypertrophic scar formation at the site of incision, inclusion cyst formations, neuropraxia due to injury to the inferior alveolar nerve, development of trismus, premature ossification occurring along the distraction segment, temporomandibular joint ankylosis or degenerative TMJ diseases, fibrous union, which is typically seen in cases of transport distraction, and damage to the dental follicle. So these are some of the complications that occur with the use of distraction osteogenesis. Now, finally, to conclude, I want all of you to understand that distraction osteogenesis has established itself as a viable treatment alternative in maxillomandibular rehabilitation. Anatomically correct regenerate coupled with decreased cost of treatment makes this an attractive option. Vector control remains a big challenge. However, correct selection of device, meticulous planning, it leads to successful and desired outcomes in distraction osteogenesis. Now I'll tell you, there are some questions which are very frequently asked during your MDS examination. They can be viva questions or they can be theory questions. Now, one of the most common essay questions that is asked is role of distraction osteogenesis in maxillofacial surgery. Then various stages of distraction osteogenesis, role of transport distraction osteogenesis in management of segmental defects of jaws, a short note on distraction histiogenesis. A long answer question can be asked on complications of distraction osteogenesis. Again, a long answer question can be asked on alveolar distraction. Distraction osteogenesis versus orthognathic surgery in management of facial deformities is one of the long questions that can be asked in your theory examination. And role of distraction osteogenesis in temporomandibular joint ankylosis. So these are some of the most common questions that are asked during MDS examination. And these are my references, which I would strongly recommend all the postgraduate trainees to read about, to go through all these articles and textbooks so that they understand the topic of distraction osteogenesis in detail. With that, I am thankful to everybody and thank you to AOMSI for this opportunity. Thank you very much.